Good morning, guys. Today we're going to tackle a very important topic. It's a topic of much debate. There are fierce opponents on each side, promoting dogma. Who is right? Who is wrong? Can there be some middle ground? Well, my TRT protocol is well balanced. So I can be objective, I can appreciate both sides of the argument and come up with my own opinion. Now, what is that opinion? Well, what's the question? I think we all know what the question is. Is Die Hard a Christmas movie or a Bruce Willis movie? It's a subject of much debate on the internet. Bruce Willis launched his career essentially with that film. However, it was set at Christmas. NWA playing in the limousine. John McClane's wife name was Holly. Ooh, could it be both? It is both. You need to have objectivity, empathy, understanding. Do not promote dogma. Die Hard is both a Christmas movie and a Bruce Willis movie. Let's all just get on. TRT should be personalised. It should be in the best interests of the patient. Dogma has no place in medicine. So what are we really talking about today? Let's talk about HCG, human chorionic gonadotrophin. Now, I've done a video or a couple of videos about this before, but I thought I'd do an update because I received an email from one of my guys yesterday proudly announcing that he was expecting a child and he wanted to thank me. My pleasure, but you did all the hard work. You know what I mean. You know what I mean. No, I couldn't be more happy for you. So what is the purpose of HCG in a TRT protocol? Is it simply fertility? Well, with microdosing HCG alongside testosterone, we have now over 30 successful conceptions. 2 of my guys have 3 HCG babies. So we call HCG the baby maker. So yeah, HCG can help facilitate fertility. HCG mimics luteinizing hormone, so it acts on the receptor in the testicle. There's also some crossover with FSH, but that appears to be genetic. So it does improve fertility on testosterone replacement therapy because testosterone monotherapy suppresses the release of gonadotrophin releasing hormone from the hypothalamus to the pituitary and the release of LH and FSH from the pituitary. So the negative feedback mechanism means that you are no longer sending LH and FSH down to the testicles. Does that matter? Does having tiny testicles matter? Well, it can do. It can cause pain. It can be acute. It can be chronic. Obviously, fertility. There are LH receptors in the brain, so it's important for the neuroendocrine system. So when you're on testosterone monotherapy, it is important to look at pregnenolone, progesterone and DHEA alongside the normal meladrin levels that you would monitor on TRT, just to ensure that you are treating this as hormone replacement therapy, not simply testosterone replacement therapy. Because that should be it. This isn't Ronseal. It doesn't do exactly what it says on the tin. Testosterone replacement therapy on its own misses luteinizing hormone and FSH. And we need to consider TRT as hormone replacement therapy. So it's funny, when we think about adding in HCG, when should you add in HCG? Only when you want to become fertile? That seems rather absurd to me. You should add HCG in at the very start. You don't want your testicles to atrophy. Why would you allow that to happen? Why would you not want maximum natural production of testosterone and then use testosterone to optimize your male androgen levels? That to me makes perfect sense. To get balanced and feel great on testosterone monotherapy and then make the decision to add in HCG to help facilitate fertility or for the other health benefits means that you will become unbalanced. So that concept is actually ludicrous. Why on earth would you do that? Now, HCG is very effective at mimicking luteinizing hormone. Is it perfect? The answer to that question is no. Why is it not perfect? Well, it's not a direct LH analog. Now, there is talk of LH analogs, but they are impractical because the release of LH from the pituitary is not constant. Your anabolic processes predominate at nighttime. So whilst there is relative stability throughout a 24-hour period, there are periods where anabolic processes predominate and catabolic processes predominate. We do need to remember that all hormones are dependent, not independent, whether that be a direct relationship or an indirect relationship. So again, it goes back to this idea of working with nature, working with the natural processes that go on within the body to help facilitate homeostasis. We want to be able to maintain a stable internal environment despite external changes. Incredibly important. So TRT should be HRT. What are the limitations of HCG? Now, because the HCG has a longer half-life, it means that it's going to bind to that LH receptor and stimulate the testicles. We want stimulation of the testicles. But how much stimulation of the testicles do we really want? Well, we want to mimic physiology, but we can't do that perfectly with HCG. However, it is the best option available to us because pharmacokinetics and pharmacodynamics mean that we want stable levels, but it comes at the expense of a slight overstimulation of the testicle. That means intratesticular production of testosterone and subsequent aromatization of testosterone to estrogen. In the vast majority of people, this is not an issue whatsoever. Now, we think about estrogen as the devil. It's not the devil. You 100% need a healthy estradiol level, but it needs to be in balance with your testosterone. So there are two organs within the body that you can directly affect a change, a positive impact, and that's adiposity, fat, and your liver. The other tissues produce as much aromatase as they need to produce. Fat and liver, sort it out. Maintain a healthy body weight. Don't pollute your liver with artificial chemicals unless 100% necessary. So it comes at the expense of estradiol. Now, what sort of starting dose do we use for HCG? Typically, and this is typically because it is based on the individual, and I'm not going to give away all my secrets, my typical starting dose is 100 IU of HCG daily. That seems to be a satisfactory dose for not only maintaining testicular size. Now, you'll probably still get about 20% decrease, but it's the lesser of two evils. Most of my guys, so probably about 30, have successfully managed to conceive with 100 IU of HCG daily. A couple of my guys have struggled, so what have we done? We've actually increased the dose of the HCG to help stimulate the LH and FSH receptor in the testicle, and it's been successful. It's come at the expense of slightly elevated estradiol, which we have controlled. How have we controlled it? With a micro, and I mean micro dose of exemestane. So it comes down to normally 1 milligram every other day, and these are 25 milligram tablets, and I use them very sparingly, and I only use them when they are absolutely 100% necessary, and it's a temporary fix till you manage to conceive, or you manage to lower your body weight or improve your liver health so that you don't need them. Everything must be in balance. Paracelsus, the dose is the poison. You can die from drinking too much water. But it's a cancer drug. It's a cancer drug. It's used in cancer to suppress estrogen. Just leave that stupid comment from the internet, because it's retarded. It's much like a vegan telling a meat eater that eating an egg is period blood. Well, fucking I love period blood then. Eggs are the perfect food source. So yeah, bring it on, period blood. No. God, what have I said? Oh, how to ruin the video. So yeah. So when we think about HCG, it's got to be managed by a professional. It's got to be managed by somebody that can separate shit from shinola.